Thank you, Mr. Chairman, ladies and gentlemen. So the topic of radiation dose can be complicated because it depends technically from manufacturers. So I will try to be synthetic. There might be a risk in cardiac CT with dose, especially in young ladies, very young. It has been stressed by Einstein in JAMA 2007, and the risk might be up to 1%, which is very high. So the first question is, what is a non-optimized cardiac CT? It corresponds to the past, what maybe it's still the present for some centers, is that a DLP might reach 2000 milligray centimeter, even more sometimes, which means up to 40 millisieverts. But we all know, and this is the subject of the topic, is that radiation dose may be substantially reduced using appropriate tools. But regarding to our center, which take care about dose, it still have a large range from 0.7 milligray centimeter in a small baby to more than 2000 when is still necessary. If you look at these two images, maybe if you want to guess which one was performed at 1.2 millisievert and which one was done at 25 millisieverts, you may guess it's the right one, which is associated with higher radiation dose because you see bypasses. But in terms of image quality, it's quite the same. The first one on the left was performed in a young lady looking for possible coronary anomaly. So we use a sequential mode, 100 kV, and the dose was around a little more than 1 millisievert. The other one, the bypass control, was performed in an 82-year-old man using a spiral mode, 120 kV, and no modulation because of arrhythmia. So the dose was more than 1,600. So what are the reasons to explain 20 times more radiation dose in the second case? It's because of the protocol. First, spiral versus sequential. Second, the absence of modulation. Third reason was the length of scanning due to bypass imaging. And the fourth reason was due to habitus of the patient requiring 120 kV. Is it clinically acceptable? Yes. Yes, because in one case it was an old patient with non-coronary artery disease, and in the other case it was a young lady, but 20 millisievert would not be acceptable at the present time for a young lady. So, in other words, optimization is mandatory. So the topic will be optimization. I will propose 4 main routes for optimization. A, regarding acquisition protocols. B, modulation of exposure windows. C, individual adaptation. And finally, we will speak about the famous iterative reconstructions. So let's go to acquisition protocols. Initially, reducing dose was done by using ECG-dependent tube current modulation using spiral retrospective triggering. And with a new machine, some years ago, introduced a prospective mode which reduced exposure time. There is 2 main prospective modes, mainly the prospective sequential mode, and for Flash and Siemens manufacturer, they introduced the spiral prospective triggering mode with high pitch. So if you are not familiar with Siemens machine, it's another concept, but it's still prospective triggering. So we can go back to the old mode. The principle is very simple, that you have the full dose typically in the diastolic phase, providing high quality image, and the tube current is reduced at 20% of the nominal dose at the systolic phase. But remark, for the systolic phase is still usable for function evaluation. Note that in some manufacturers, here Siemens, you can go down to 4% using mean dose systems. And globally, this system was able to reduce the dose from a factor of 30 to 50%, and the lower heart rate, the higher efficiency in terms of reduction of dose. This is why beta blockers was useful also to reduce radiation dose. But with this spiral retrospective mode, the level of dose was still considered as high, between 7 and 15 millisieverts, but as still an advantage is that function is accessible. Now there is many publications validating prospective ECG-triggered sequential acquisition, and here you are no more in the spiral mode, but in the sequential mode you have a shot typically in the diastolic phase, then the table moves, and there is another shot, and so on, and you need 4 shots with a 4 centimeter wide detector, 2 shots for 8 centimeter wide detector, and just 1 shot, 1 bit acquisition with the large 16 centimeter from Toshiba. The exposure time is short. There is not the problem of overscanning due to the spiral mode, which increases the radiation dose, which exceeds the area to be imaged. And 100% of radiation which is emitted is used for image, if you don't use padding. But the drawback is that you have only one phase, and this is typically validated in the diastolic phase, but it's also possible to perform prospective sequential acquisition at the end systolic phase. Typically, you can have a radiation dose of 1 or 2 millisieverts using, for example, 100 kVp, and you have very nice image quality. But in real life, it's true that step artifacts are frequent, and there is some limitation in real life. However, the mean dose is low, is between 2 and 5 millisieverts, and you don't have function 2, which can be a limitation in some cases. Now, the high-pitch spiral mode is a specific mode of acquisition from Siemens, with a pitch of 3 to 3.2, which is 15 times faster than the 0.2 pitch value usually used for spiral retrospective acquisition. So the good thing is it's a 1-bit acquisition, which needs about 300 milliseconds to scan the whole heart. But with a new generation of Siemens machine, it will go probably down 180 milliseconds. So we are looking forward to see the results in terms of heart rate and feasibility. So this is performed by mixing two spiral in the same time, and you can acquire typically images only on the diastolic phases. So by combining low kV and spiral mode, you can have nice acquisition for less than 1 millisievert. So in practice, in clinical practice, there is the main drawback is that it requires low heart rate, below 60 beats per minute, if you want to be sure of image quality. And you don't have functional information. Now let's see the second main road, which is the modulation of exposure window. In fact, one should guess cardiac motion during the cardiac cycle. So to better understand, we conduct a study using Doppler tissue imaging, which provides you heart motion curves at growing heart rate. So this is personal data. It's my heart motion to be precise. And at 60 beats per minute, you can see the variation of motion using Doppler imaging. And you can see that you have a long window of low motion. The low motion is under the dotted red line here. But you have also a small phase of low motion at the systolic phase at around 30% of the RR interval. Now, I did some efforts, so my heart rate went up, and you see what's happened. When my heart rate was 77 beats per minute, the low motion phase during the diastole was considerably shortened. But there is still a low phase in the diastolic phase. So after more exercise, my heart reached 100 beats per minute, and at this time there is no phase of low motion on the diastolic phase, but you have still a systolic phase with low motion because it's the end of contraction of the heart. So it's always a time point when the heart doesn't move. So finally, we found that that the systolic phase is more robust than the diastolic phase because it's always present in the end systolic, and it varies from 35% of the RR interval at low heart rate until 50%. But the drawback is that the temporal window is short in systole, so you need to have high spatial resolution to use this property. But of course, if your heart rate is low, everybody knows, I think, that you can go safely, make safely coronary imaging in the mid-diastole. So, to make things simple, the optimal window is surely the diastolic phase around 75% of the RR interval if you are below 65 beats per minute. If it's over 70, you can, if you want to be on the safe side, you can give radiation dose between 40 and 75%, and you will be able to get two phases. Or you can even reduce the temporal window between 40 and 50% of the RR interval, and you will still have one phase with low motion. But of course, this works when the rhythm is regular. In case of arrhythmia, or if you need functional analysis for some reason, or valve analysis, probably you will need to do spiral or imaging or sequential with a large padding. On the safe side, it's between 30 and 90%. Typically, when pediatric application, you need low dose because this is children. Children have high heart rate, and you have to be as low as reasonably achievable. In this young patient, 6-year-old patient with heart rate of 120, we use, and it's our routine to use systolic acquisition in sequential mode at 40% of the RR interval, or just at the peak of the T wave. It's more or less the same, using low kilovoltage settings, which account after correction to the body size, because the DLP given by the manufacturer is not always exact in babies, so it makes around 0.6 millisieverts. So you can see nicely here coronary arteries in anomalous left coronary artery rising from the pulmonary artery. So the third road is individual adaptation. First, it means that scan coverage should be as short as reasonably achievable. In fact, it should be adjusted by the radiographer, and they should learn how to scan the heart, and only the heart, not the pancreas, for example. And also there is an open question about the ideal adaptation on KV and MAS, because it should be ideally different for every patient, each patient, depending on their own attenuation. You know that reducing KV provides drastic reduction of dose to the patient, because dose varies with the square of the kilovoltage. And for example, if you move from 120 down to 80 kV, the radiation will be 2/3 lower. But of course, it depends also in terms of image quality of the patient's morphology. And to be simple, in patients lower than 80 kilograms, you can achieve good cardiac imaging at 100 kV, and you can have also good image quality in patients at 80 kV in patients below 65 kilograms. And the main benefit is not dose and noise, but more contrast, and you have better contrast to noise ratio due to the photoelectric effect. So individual adaptation. There is some tools provided by the manufacturers who provide automatic adaptation and automatic adjustment of KV and MAS, but you can also do it by yourself. And we conduct a study including low KV protocols, and we just use the pre-control scan as a reference using a single slice, which is used to put your ROI over aorta and to detect the bolus arriving in the heart. So this is currently done by the manufacturers in our centers. On the pre-controlled non-contrast CT, they just put a ROI over the heart and read the standard deviation on the ROI. And by adapting progressively the levels, we made a chart with different KV and MAS, and you see the range of dose for, depending on the patient morphology, range from 10 to 84. And with this protocol, just read the noise here. You can have the similar noise for the majority of patients with very different range of radiation dose, except for the range of low KV, which was given more for children. And now we reach the fourth road, iterative reconstruction, which have been intensively promoted by constructors. It's a new algorithm to reduce noise in images. It's a reduction of noise, it's not a reduction of dose. But of course, reduction of noise may help in reducing dose, but it's still a black box which provides also a different type of image. So you have to be careful, because there is also different generation of iterative reconstruction. So the image quality is not the same for every manufacturer and every generation for the same manufacturers. So in the literature, we can expect 30 to 50% reduction of dose for a similar image quality, but also the range of reduction depends on the initial level of radiation dose. Now the four roads are joining to become what we can call the ultra-low dose highway. If you combine prospective mode, optimal windowing, individual adaptation, and iterative reconstruction, these have really an additive effect. So it is now possible, and we have very interesting new papers in this subject, to provide cardiac CT below 1 millisievert, which can be considered like ultra-low dose protocols. So there is a first paper last year using Sapphire and Siemens with a very, very low range of dose of 0.06 millisievert, which is 300 times less than the first CTA. And 2 weeks ago, there was a publication from a group working on GE with something similar with 0.2 millisieverts, and the basic principle is the same, is a combination of low KV, prospective triggering, and last generation of iterative reconstruction. So is this ultra-low dose protocols ready for routine? I think not yet, because the studies included selected patients with a very low proportion of diseased patients. In these studies there was some case of very high level of noise, and the evaluation of stenosis was not performed. But it may be well suited for screening purpose, and it introduced new concept of low-dose scanning for screening. So in conclusion, recent CT machine allows to decrease massively radiation dose by mainly reduction of exposure time and the use of iterative reconstruction. Don't forget individual optimization. And now we can say that radiation dose, this is the main and good point, is lower than angiography and nuclear medicine. And we think that dose is not an argument against cardiac CT. Thank you for your attention.